Welcome everyone to the Health Storm. I'm Vic, your host. Have a really great show today. Chris Cigarran, CEO of Imagine Health. I've known Chris for about 20 years. That entire time he's been focused on helping large employers really deliver better care at a lower cost to their employees. We dive into Imagine Health, his company, as well as the overall health market. It's a great show. Please watch. I think you'll enjoy it. Thanks a lot. Okay, welcome, Chris. Thanks for doing this. I really appreciate it.
Happy to be here.
Obviously, we've known each other for a long time, longer than I really want to think through. We're both only 25, so
That's
we
true.
can't have known each other for 20
Yes.
years. But give a little bit about your background. You were at Healthways and now Imagine.
Yes.
Tell the audience about this.
Great. So I started at Healthways here in Nashville back in 2001. I worked there for about 13 years. Did a lot of different roles. I ran HR for about 5 years when the company was going through a phase of rapid growth. I think when we started, we had probably 600 employees, grew up to about 4,000, about, $65 million in revenue, up to about $700 million in revenue. So it was a lot of fun. My last role there, I built the employer and government division with a great group of people. Did that for about 4 years and then decided that I liked the growth part more than the sort of maintain the status quo part, and left Healthways in 2014 to join Imagine Health out in Utah.
Yeah, and so you were going from the employer and government division to servicing employers. But from how many employees at Healthways to how many at Imagine?
Well, yeah. So the interesting piece was actually I went from being an HR person,
Right.
and being
And
responsible
then-
for benefits
Right.
and working with the BUCA carriers.
Yeah, you're almost like full.
Yes. To then selling to HR people in the employer division, and then at Imagine.
So do you
as
know
well.
their tricks and like the way they stall or the way they get around things?
Yeah. I knew from my experience in HR that someone had to be able to do what the carriers were doing better. Let's just put it mildly. So tell me your question again. Sorry.
Well, I just was going to start with how many employees. So Healthways was pretty big.
Yes.
And then Imagine much smaller. But just give me the frame of reference. Like what about?
So say, at its peak with Healthways, we had about 4,000 and then probably 25. Imagine.
Right.
So it was a pretty significant difference.
Yeah.
But it was more of what I really loved to do, which was, not a lot of things written down, a group of passionate people committed to a mission, sort of changing the world. And
Let's make a
worrying
difference.
about-
Let's not make a lot of policy.
Exactly. Yes. Yeah. Not policy, procedure. Well, that's the right thing to do, but the rules won't let me do that.
Right.
We didn't have, and we don't still have a lot of that. It's more do the right thing for the customer, do the right thing for the mission, and the rest of it will take care of itself.
So talk through I want to spend a little time on the Imagine mission and product, because it's pretty different from a lot of products that people might know about.
Yes.
So explain what Imagine does.
So great. So from a mission perspective, we're really trying to change healthcare, how healthcare is delivered in the self-insured, the commercial space. The traditional model, maybe I'll start with that.
Yeah.
If you go to one of the big carriers.
So self-insured would be anyone who has over 1,000 employees.
It's actually now down. It's under 100.
Okay.
In
So
a lot of
basically every
cases.
employer, almost every
most
employer.
employers outside of the really small employers are able to find a way to be self-insured.
So self-insured is very close to the sort of employer-sponsored healthcare.
Employer-sponsored healthcare is the best way to put it.
Okay.
And so if you think about the product that probably 95% of employers purchase, they go to one of the big carriers, Blue Cross, United, Cigna, Aetna.
Yeah, that's the BUCA you were referring to.
Exactly, yes. Thank you for translating that. And what they buy is, and if you think about what is a health plan, it's a network, it's the member experience, whether that's the call center piece, and then there's the TPA, the third party administrator, which is generally paying bills. Right.
Yeah, processing claims,
generating explanation of benefits, paying bills, that kind of
right.
stuff.
And so let's just break that down, because a lot of my audience is not healthcare insiders.
All right,
so
good. That's good to know.
When you say network,
Yes,
you mean the list of doctors that are on this insurance plan that would accept payment from there, have a deal covered.
exactly. So what the big carriers will do is they'll go into a geographic area, and if you're a doctor or provider or a hospital, they're going to sign you up to be in their network.
They kind of sign everyone up, I think.
Yeah, that's exactly right. So generally they'll have in any geographic area, 92 to 98% of the available providers will be in their network.
Yeah.
It's a really interesting way to buy anything. I always use if you're at a large employer, they're not going to say, go rent car. You can use any rental car company you want to, right? They're going to say,
use this one.
Use National.
Right.
And
if we don't like National, then we'll change next year.
Exactly. They don't say go anywhere. And the rental car cost within an employer are, I would suggest, much lower than the healthcare costs.
Right.
But with healthcare, employees are allowed to go anywhere in these broad panel networks, which means everybody's in.
I mean, maybe they're allowed to go. They are on the Blue Cross network or the United network, and then it happens that those networks have every doctor.
Yes. So there is no differentiation between the networks of the major carriers.
Yeah. And the network brings a negotiated price associated with it.
Yes.
Right. So based on what, like Blue Cross here in Tennessee has, 10 or 12 networks that are Blue Cross networks, but they have different features, different prices, different deals. From my point of view, you know more, but that's my ad-libbing on it.
Yeah, I think if you actually got the data, which you probably couldn't get, but if you got the data, and since you can't, I'll just opine about it. If you got the data,
you can't be wrong.
Exactly.
So
for a self-insured employer, they're going to generally have the same broad panel network that every other self-insured employer is going to have, and they're going to pay whatever those contracted rates that Blue Cross has with that provider. Yeah. There may be 12, but probably 90% of the employers use the same one, which is the everybody in, no differentiation based on cost and quality outside of the 3 people out of 1,000 that get on an app and can maybe figure out where to go. But generally, they're going to search for a provider based on location. Right. If you think about how you search for a restaurant, it's generally not based on location; it's based on stars.
Right.
But when you're choosing a doctor, it's who's closest. It's a sort of scary thing to think about.
Yeah. So the traditional that Imagine is reimagining, but let's start with is a network, which is every doctor.
Yes.
And a negotiated price around that.
Yes.
It's you said the experience. The experience is pretty poor.
Pretty poor.
But the experience of getting your card and fighting with insurance companies, I guess, is the experience.
Yes.
And then they
or like
process
calling
claims
in to get a new card or calling in to ask about a bill, and that's that.
Yeah, I get my EOB. They spend a lot of mail on EOBs.
Yes, EOBs, which make no sense to anyone. Right. Absolutely.
Okay, so that's the traditional model.
Yes.
How is Imagine blowing that up?
Great. So what we've done is we've gone into select geographies, and I'll use Dallas as an example. Okay. And we use proprietary data, both commercially available data and then publicly available data. We torture the data to figure out what is the quality that exists within a specific geography. So in Dallas, we look at all the health systems. We compile that data. We're looking across 6 high-level clinical categories to understand sort of who's good and who's bad at a high level. Mm-hmm. And then what we did in Dallas, and we do this in all of our geographies, we're figuring out who would we want to work with based on that quality data, starting at a health system level.
Who has the best quality? Best is complicated, but you're trying to figure out who is the best.
Who is able to provide, in the end, our clients with high quality healthcare.
Okay.
And so that's what we start with. So we look at if we pick, then we pick
and you'd prefer to pick an entire system. So that would be the doctors, the hospitals, all the different component parts.
So starting with the hospitals, right? Because generally a hospital will come with some physicians, but not all the physicians in a geographic area. Yeah. So we pick the hospitals, or the health system, and then within a health system, you're going to have multiple hospitals. So Baylor Scott and White has, say, 26 hospitals in the Dallas-Fort Worth area. Within those hospitals, there's going to be a varying degree of clinical excellence, and so we're looking at 37 different clinical categories, even within those hospitals. Then when we select physicians to be in our partnership, we try not to use the word network. We try to use the word partner. Yeah. So we're selecting physicians that are referring into high-performing clinical categories within our partner hospitals. And so what we're trying to do is make the quality option the default option within
and if an employer signs up to the Imagine system, you have partnered with the the best doctors and hospitals that you can find in the area. Now, it's very complicated to measure what is best, but you have people and data and you're working on that.
Yes.
No one else is trying to do it. So whether it's perfect or not perfect, I don't want to worry about it. It's a really good attempt at the best possible care.
That's exactly right. And so I think, as a country, we've said it's really hard and it may not be perfect, so we're not going to measure it. Our perspective is
it's really hard, so let's just not do it.
Exactly. And I'm getting an age now, we're getting an age now where whether it's us or our kids or our parents are using healthcare more and more.
Yeah.
I want to choose healthcare based on data. That's how I choose everything else. And the data is out there. Although it's not perfect, it's better than not using any data. And time again, we see that in the care that we're able to
and if there are 100 choices, let's say 100 of one type of specialty doctor, I don't need to get to like, this is the top one.
That's exactly
right.
But
get me into the top 10, and then that's probably fine. I don't want to be with the 100th best.
That's exactly right.
Yeah.
There are a lot of studies that say if we just cut out the bottom 50%, we would increase the quality of care significantly and significantly decrease the cost of care in the country.
And so let's get to that, because what's really amazing, but I think you're going to say is true, is the top quality health systems and doctors will deliver the least expensive or competitively priced service offering.
Well, so you have two different things that are working together here. Okay. So one, back to the broad panel network where everybody's in, right? If everybody's in, then why would anybody? You'd have to be crazy to be the lower cost provider. Nobody knows the prices. There's no differentiation. There's no steerage. So why would you ever be the one who's going to provide the lower cost care? Just
you get no benefit.
There's no benefit from being lower cost, and so why would you do it? And so when we go and partner with a system, right, part of our value proposition is, look, we are going to steer volume to you based on the fact that you're a high quality system. In exchange for that, in exchange for cutting out your competition in a specific geography, we need
so let's just
rates.
Take my example. Like we've decided you're one of the top 10 cardiologists in Dallas.
Right. So use Nashville.
Whether you're okay in Nashville, whether you are number 1 or number 10 is immaterial.
Right.
We think you're really good. We're going to steer all of our patient volume to you, and that's going to increase the volume of your business.
Right.
And you will get much more volume. And so will you give us a slight break on the price per procedure?
Right. Yeah. And starting on the hospital side, right? If you look at cost, right? So on the hospital side, there's probably more opportunity. You think about hospitals and staffed bed occupancy, right? There are empty beds in hospitals, and so there's room for more volume. And so there's the opportunity.
There's a lot of fixed cost in hospitals.
A lot of fixed costs.
Yeah.
Absolutely.
Yeah.
And so there's a big opportunity there, right? And so, and the volume piece is one piece of it, right? The bigger piece is it's not just lowering costs by paying less for care, right? You're actually paying for less care when you're using a higher quality hospital, a higher quality physician, right? Fewer tests, fewer readmissions, all the things that really drive up costs. When you're driving volume to higher quality physicians and hospitals, you're getting rid of a lot of the waste that's in the system. So
there's sort of two aspects on the cost side.
Yes.
There's just a pure price change.
Yes.
But there's also a sort of a, let's do it right the first time.
Let's
get them in the right place. Let's not do wasted diagnostics.
That's exactly right. Yeah. I mean, I've gotten in the habit of, one of the clients that we work with, he said, hey, okay, and I'll say this over and over again, it's not just paying less for care, it's paying for less care.
Yeah.
You can save a lot more money by paying for less unnecessary care than you can by any kind of discount game.
Yeah, and your employees are happier.
Well, exactly. I mean, nobody wants to spend another day in the hospital, get readmitted, have more procedures. I mean, we don't choose to access the healthcare system generally.
Yeah, so do you have any kind of stats or case study, or has Imagine worked with a client long enough to have results?
Yes. We've consistently driven from just a cost savings perspective between 15 and up to 30% savings in the first year, and then we're able to hold on to that savings year over year versus a traditional solution. So it's something that I spent, back to sort of my history, I spent a long time in the disease management and wellness
Yeah,
business.
trying to get pick up pennies.
Yes. Well, and again, at its heart, right, getting people to exercise, eat better.
Yeah, it's good in general.
It's good in general, and inherently you have to believe that saves money. It's really hard to prove it.
Right. I mean, you have to believe that in the next several years it'll be good.
Right.
But you're saying 15 to 30% in year one.
In year one.
So that's pretty, I mean, you can believe it's super nice for the employees, and the CFO gets 20% savings right now.
At the end of the day, right, it's about health outcomes, and it's about saving money. And if you look at where benefits have gone now in high deductible plans, and if you make $40,000 or $50,000 a year, or $60,000 or $70,000 a year, and you're on a high deductible plan, and you have a family deductible of $10,000, HR people worry a lot, and having been an HR person for a long time, you worry about disruption and trying new things. I would suggest that a high deductible plan is about as disruptive as you can get.
Yeah.
Because
I mean, if you're making $70,000 and you have a $10,000 deductible,
guess what?
It's a lot of money.
Yeah, you go to the hospital and you're generally not paying for. You're not going to pay your bills, which then I think I don't remember what the latest stat, but it's like 49 million Americans are some kind of bankruptcy due to healthcare costs.
Right.
It's crazy, and so we come in with a solution that says, look, your biggest line item, second only to payroll, we can take 15 to 30% out of that in the first year. It's a pretty big.
Yeah. So let's
impact.
just repeat that and underline that. On all the things a company pays for.
Yes.
Payroll, people's salaries, and the cost of the workers is number one.
Yeah.
Health
generally, right? I mean,
it depends on the
maybe
industry.
you're not if you're in aerospace or something.
Yeah,
like that,
but across the board, mostly the salaries and payroll is number one. Health benefits is number two.
Yeah.
And you can take 15 to 30% out.
Yes.
Year one, and then it holds there.
Yes.
Versus growing at different rates. But
and
growing pretty
medical
fast.
inflation, right?
Yeah.
I mean, a progressive employer will say, hey, we've got trend that's down 3, 4, 5, 6%. We see employers every day that are dealing with 9 to 20%.
Right.
I've had a new client just the other day say, look, we're doing this, fill in the blank, large carrier just came back with a 20% increase for next year. We can't afford that. And we've got to do something differently. And I think more and more sort of real American businesses are dealing with that every day and are looking for something different and something that's beyond wellness services and apps and things like that, something that actually can cut into the core of this cost crisis.
Yeah, because I mean, the wellness things and apps are good.
Absolutely.
But people have been trying those for a long time. And we'll keep trying them, but they don't have that kind of impact.
That's right. So, back to the what is a health plan?
Yeah.
When we looked at this, we said, look, if you really want to address cost, where does cost happen? Cost happens where care happens, and care happens in the network. And so if you look at innovation in healthcare, not many organizations have been willing to go there because it has become such a natural part of self-insured insurance. And we said, if you're going to make a difference, you've got to deal with that piece of it.
So I want to dive into that because that's confusing to me.
Okay.
And so, I mean, you've been at Imagine several years.
Yes.
You have great results, and employers are signing up.
Yes.
And yet, a lot of people that are watching will have heard this for the first time right now. And kind of high performance, my super fancy
somebody's
studio.
going to the hospital right now. That's good.
It hasn't caught on like wildfire. Like 30% is a lot of damn money.
It is a lot of
why isn't every CFO in the world like lined up outside Imagine saying, I want to do this?
Yes.
What's the stumbling block? What keeps it?
Yeah, it's a wonderful question. We spend a lot of time talking about this.
Yeah, I'm sure.
I think the first piece is benefits historically within human resources have been focused on providing coverage, providing care, and haven't really fallen into the purview of the CFO, where it's more of a numbers game, right? And looking at the cost of care, the cost to an employee, and the real impact to the business. And I think we're seeing that shift. What the focus has been, how do I add services to create less noise within the organization, less phone calls into HR, as opposed to this is a really broken game that I'm playing, and I've got to play a new game. And I think we've continued to try to add things on as opposed to looking at the fundamental plans that we buy every year and how do we just do that differently.
Yeah.
And it's hard, right? It's hard to go to an employee base and say, hey, the Blue Cross Blue Shield that's been on your card for the past 20 years, we're going to try something different. I would suggest, though, it's easier to have that conversation with your employees when you can also say, and we're decreasing your deductible for the first time in 20 years.
I mean, everything's hard. Right?
Yes.
Like, so maybe it's hard, but companies do hard things all the time. It's hard to lay off 20% of the workforce. It's hard to do lots of things, and yet they do them.
Yes.
So I don't know. There's a weird thing about healthcare that I'm trying to explore, that it's almost like a societal, cultural thing. Like people believe it's their American right to be able to go to any doctor they want to at any time. And
that's the system that we've set up, and that's the expectation that we've set up. And I mean, there's a great thing that I listened to probably several years ago when we were just getting going at Imagine, and someone had done a bunch of research, and they said, inherently, my experience is that I'm not sure that HR people really want to save money in healthcare. I mean, I've experienced, thank goodness, lots of great HR people who do want to save money. And again, I come at this as an HR person, but it's hard. It's a really hard conversation to go and change something that has really been the status quo for a long time.
And anything new is kind of scary.
It is. Yeah. It is. And when you're dealing with people's healthcare, that's a core piece. It's different, again, back to my car rental thing. It's different than changing the rental car, right? People get upset about that. And imagine when you talk about changing their insurance. But, you know, I think we thought high deductibles were going to fix everything and making employees, you know, consumers. And what we did is we just shifted the cost to employees. And now they can't afford their care.
Yeah, and they like their doctor because, I don't know, their neighbor went there, or they heard something there, or they went to a kid charity event and they were sponsoring it, which is ridiculous because they shouldn't be doing that.
Well, I mean, you look at the hospitals, right, and just in the area that we're in, and the marble lobbies, the valet parking, the McDonald's in the cafeteria. I mean, the things that we choose
because that's really needed to health.
The ER billboards. I mean, all this stuff is a little bit crazy and not necessarily how we should choose where we get our care.
Right. Yeah. Okay. So, welcome to the show. That's a great background. I think it's called Health Storm.
Yes.
Because I see in the next 5 years, a pretty big storm coming to the health industry, almost like a hurricane that we can see on the horizon. It's coming, really due to 4 trends. And so I want to talk through them and get your feedback on the trends. So the first plays right into Imagine, which is the rise of the consumer. So people are trying to take control of their own health. And in your example, employers are trying to help their employees take control. And you may say that you can just go anywhere and it's an all-you-can-eat buffet, but it also may be like, let us help you with data and with the right network.
Yes.
Do you see that as a trend of people trying to like get more authority and decision-making?
It's funny because our sort of tagline is take back control.
Right, there you go. Okay,
it's a great plug. Okay. And we really do see it as exactly that, right? Where, people have been trying, again, with really good intentions to do something differently. And we think that we're at a point now where they don't have a choice, where they recognize the impact that what they're currently providing to their employees is bankrupting people.
Yeah, I mean, well, and yes, it's bankrupting their people. It's also, if my second biggest line item on expenses is growing at 20%,
yes,
I can't keep that going.
Yeah, and so now we're getting forced to make hard choices, right? Because you can't turn the knob anymore on high deductibles. People recognize we can't do that anymore, so we have to do something different now. And how do we start investing more money in the business, or giving, increasing wages, or hiring more people, or property, plants, and equipment? All those different things that you need to spend money as a CEO on, or a CFO on. It's got to come from somewhere. And if there's the opportunity to increase the quality of care and decrease costs, why wouldn't you do that?
Yeah.
And so we
so Imagine is a great brand, and I like that take back control. There's not a lot of brands in healthcare that are empowering the consumer.
Right.
And I think that is going to change in the next 5 years.
It absolutely is. I mean, another sort of neat part of our solution is what we sort of called price protection, which is the whole thing around surprise billing, where it's out there. It's interesting that
but on Imagine, you would have network coverage, right?
Yes, but even in a broad panel solution, right? You look at the data. That's where surprise billing is happening. Right?
I thought it was out of network somehow.
Yes, but so think about if you have any large carrier, even if they have 98% sort of in quote unquote in network under contract, there are still surprise bills. And so how do you protect people when that does happen? And we've got a great solution where we look at both the cost of care and what Medicare pays. Yeah. And we're willing to pay what we believe is a fair and reasonable rate. You look at ERISA, not to sort of geek out too much on on how healthcare works or should work.
Yeah, I would call that
people on it.
Reference-based pricing.
Yes, and that's one of the sort of the monikers that's used for that.
Okay.
And sort of within a solution.
Yeah. Okay. And then another trend is care is moving kind of out of the hospital to the neighborhood or the home. And so more and more things that used to be done in an inpatient facility can now be done faster, cheaper, more effective, better for the patient.
In outpatient facilities in the home. Absolutely. The hospitals are changing. Yeah. At least in theory.
They're going to change. Whether they know it or not is a question. But
yes, there's a little bit of a golden goose mentality here, and depending on the systems, and I get to talk to a lot of systems, you'll find some that are way out there on the innovation side, and I'm not talking about fancy tests. I'm talking about thinking differently about how they provide care, and others are more addicted to the old model, and we tend to choose to work with the ones that are really thinking about the future.
Yeah, so let me jump to one of the impacts. I think these trends and the storm coming are going to result in 1,000 to 2,000 hospitals closing. And it's going to be the ones that are not paying attention, not innovating. And you're exactly right. It's the clinical care, they always love to play with new toys.
Yes.
But it's the business model innovation. How do they partner with Imagine? How do they rethink how they go to market? Can they get care out of their four walls and into the community of the home?
That's exactly right. If you think about in most major metropolitan areas, and I think the rural areas, there's a different problem, a different crisis that's going on there.
Crisis,
Yes. But if you think about in a big city, think about Nashville.
Yeah. Nashville, Dallas, Atlanta, Phoenix.
Right. The number of large hospital systems in Nashville, right, within a mile is I would suggest generally more than we probably need.
Yeah, I mean, I think it's double the capacity we need.
Right, and so there's some great studies that have been done about does the capacity drive the volume. Right, it's like the air in the box theory, right? So because the box is so big, it fills up with air. Right. Because we have so many beds, the beds tend to fill up.
Right.
And not because of bad people or perverse incentives, but just that's what happens in the system. And so I think if we let competition take place in healthcare in a positive way in the forces of the market, we'll probably see some positive change.
So if a hospital partners with you and they do a really good job and they get more volume and that employer's happy and they tell other employers, that hospital will get more and more volume and other hospitals in the market will die on the vine.
Our job.
I would say that.
I wouldn't say it. You would say that. I wouldn't say it that way. I would say, we're creating the opportunity for our partners to benefit from providing high quality care at an affordable price to our employer clients and create a direct partnership with those clients. Right. So historically, the hospitals have been disintermediated from employers. They've had to go through sort of an intermediary, and we try to create a direct relationship. And, I think health systems who are less willing to create that kind of partnership, who really like the old model, we'll see what happens over time.
Well, you have to be more politically correct. I don't have to be. So that's the glass is half full. Like your partners are going to be really working with the employers much more directly, not disintermediated. Imagine brings them together versus the buca that sort of like keeps them apart. And it's true, I think that if we have double the capacity we need, that some of the hospitals are going to be totally empty.
Or maybe have to change their business model.
Yeah,
right.
yeah.
Which is, I think,
shut down, and you can put an apartment there. So, let's move on.
Your words, Evan.
So the other trends are sort of tech tools growing in power. So this is telemedicine, AI, machine learning, kind of all the different data science pieces that are making us smarter. And every other industry are now coming to healthcare in the next 5 years.
Absolutely.
Yeah. So when you say torture the data and find the right places to partner with, it's not perfect. Nothing's perfect.
Right.
But you can find the better, on average, better results.
Absolutely.
Through these
look at the Medicare data set, which is gigantic
and widely available.
Yeah. The idea that a commercial patient gets treated differently, and I had this conversation last night at dinner, than a Medicare patient.
Yeah, the doc doesn't even know.
Exactly, right? Yeah. So it's a great data set
Yeah.
to use to look at outcomes-driven quality data, and that's one of the large data sets that we use. So again, back to your earlier point, the data's available. It's not perfect, but it's really good, and it can help you make a much better decision maybe than you're currently doing.
And then there's new big players coming into the market, right? So I see Amazon, Walmart, Google, Apple, all kind of jumping in, and they have different strategies based on where they want to attack the marketplace, but they're not scared about the cute little health companies.
That's right.
Because they're 10 times the size, 100 times the size.
That's exactly right.
And they understand all these trends. They understand consumer branding. They understand unbundling things and getting solutions, make it convenient. They understand technology, certainly.
Yes.
They're going to be very formidable competitors. So the big health brands today that feel comfortable that they are the bully in the schoolyard
and have been for 40 years.
Their competition is not going to be the other kids in the playground, right? There's a new player coming in
who could come in. I mean, and even the biggest ones,
right? You can buy them with cash on the balance sheet and not
easily.
Even materials.
That's exactly right. Yeah. And I think healthcare is so insular. It's really hard, and put myself in this. It's hard to even think about that happening, but it is absolutely a possibility.
I think it's going to happen.
Yeah, and I would have a hard time arguing that it's not. And then when that happens, then what? Right. I mean, that is
Well, they're going to look at the business of healthcare and hospitals and delivering care very differently, like they would look at doing a search or delivering a package, or Walmart, bringing the best price to their.
Right. Well, and if you look at just the math behind care, right? So put the quality piece to the side for a second and just look at things like billed charges and discounts, and I think whether it's an Amazon or a Google or whomever it is, or Walmart comes in and looks at that and says, I'm not sure I understand why the heck it's priced this way.
Yeah.
And why do I care about the discount percentage when it's off a made up number?
Right.
I mean, it's
I think they're
nonsensical.
My opinion is in the next 5 years, they're just going to run over that.
Yes.
And say it's $3 trillion. We can cut it significantly to $1.5 trillion, and there's still a lot of margin.
Oh, there's absolutely,
because there's so much waste.
Yes, without question.
Right.
I mean, we can look around.
Right.
Being in this town and realize that's
this storm is coming. Whether it comes in 6 months or 5 years is harder to predict.
Yes.
But the idea of this podcast is to try to think about, as it comes, where do we need to kind of put plywood on the windows and protect ourselves, and where can we invest that's going to really benefit from. And the reason I wanted to have you on is I think Imagine is an example of how the employer-sponsored health can really lead us into how should this country do healthcare.
Absolutely. You think about, and some people know this, some people don't. I would say hope most people do. But if you're a provider at a hospital or a physician, the commercial business, self-insured commercial business,
it's all the margin.
That's exactly right.
Yeah.
And so the value of a commercial life to a hospital or a provider is significantly more valuable than a Medicaid or a Medicare life.
And that's right. And I was talking to a very large auto worker company, maker last week, and they understand that, and they're kind of tired of subsidizing all these other people.
Yes.
And so they have a lot of employees they need to get care for, but they aggressively push pricing on every other thing they buy.
Everything.
And they're ready to turn to this.
Yes. It's amazing, right, that it's
taken so long.
2020,
really, right.
and we're, it's like we've been talking about this for a long time.
Yeah.
How is it that you don't buy anything like this? And how is it that you haven't even really looked at it for a long time? It's all been, given to the health insurance companies to worry about. And if you think about it, right, they're administering claims and paying bills with the employer's money. And a fascinating thing that I've learned.
And the bigger it is, the more they get.
Yeah. Well, think about this, though. If you go and you understand the language that's used in healthcare in the commercial space, if you go to most hospitals, what the insurance companies are called the payers, right? In commercial in the self-insured market, the health insurance, they're not the payers.
Yeah, they're the claims processor.
The employer pays. They take the check from the employer
right.
and hand it to the hospital, right? So, they could.
The reason they have that title is they negotiate the contracts.
Well, and they
have
done a great job of putting themselves in the place where they are the payers, right? In the fully insured business, absolutely, they're the payers.
Right. But that's a small percentage.
Depending on the carrier. Yeah. And even in that case, right, it's really the individual, that's the payer, right? And they're taking a spread on it.
Yeah, but just to make it clear, the employer, if they're working with one of the Buca companies, they're paying 3% in like an administrative fee. Mm-hmm. Depending on how big they are, maybe 2, maybe 4, but they're paying a percentage.
Yes. And
so the more they pay, the better it is for the carrier. It's pretty simple math. Like if it's $100 million, 4% is less than if it's $500 million. Okay, so the thing I want to move to is in healthcare, timing is really everything. Right?
Yes.
So this change is coming.
Yes.
The question is, when is it going to hit? Healthcare is highly regulated. It's hard to disrupt. It's kind of emotionally charged. And change comes kind of slowly. The edges change first. And so what do you think the segments are that will be the first, what's the canary in the coal mine? What's the first thing to look for that could change?
Well, I think you would think that employers would be the ones to drive change.
The reason I want to talk to you is I think employers and Medicare Advantage are the two places.
Yes,
that
it's been fascinating to look at innovation across the board, and a lot of innovation has come in the MA, in the Medicare Advantage business. In the state of Tennessee, a lot of innovation came in the Medicaid space. Darren Gordon drove a ton of innovation here in Tennessee that sort of looked upon across the country as really a great model for what's possible. Not easy, but what's possible.
Yeah.
I think the employers have got to be the ones who drive change. Again, though, I think what we need is progressive HR people who are willing to challenge the status quo and really face up to the fact that the status quo is severely broken and riskier than what's out there in terms of new things. And I think we also need CFOs to become more involved in healthcare. It boggles my mind that CFOs haven't been more involved to this point in healthcare costs. I've worked with clients in the past that are spending, 1 to multiple billions of dollars on healthcare, and it's been more of an HR opportunity and issue than it has a CFO and a finance issue. I think it's both. It's the impact on the human engine of the business, but it's also an impact on the financial engine of the business. I think when those two groups come together, it'll change. I
don't think it makes sense to just cut and not provide benefits or go to really poor health systems.
I totally agree.
But the point is, if you're spending $1 billion a year on this, I don't care how big the company is. It's a lot of money.
That's right.
And let's try to spend it wisely.
Yes.
Let's try to get some value out of it.
Without question. Yeah. And there ought to be...
They probably spend more time on their paper plates in the lunchroom.
Right. Direct, serious, stern conversations with the providers of that service about how can you do it better, faster, and cheaper, just like everything else, right? Yeah. I think that time is coming. And again, it's a big market. And you're seeing a lot of innovation now. I would suggest over the past 10 or 15 years, a lot of the innovation has been more peripheral than it has sort of right at the core of driving real change. I think now you're seeing more and more organizations that are really focused on driving what I would call as real change.
And so employer sponsored is $1.3 trillion, $1.3 trillion, $1.5 trillion.
Yeah.
So that would be 1,300 billion, 1,500 billion a year. Most of the big companies in this space are shorts, I think. Like in the public markets, people are looking for places to invest money.
Yes.
Most of them are going to go the wrong way. And so I'm looking at where can we make investments in private things, and also there's market entry. Like
That's right.
So well, maybe not be a healthcare name, but someone else is going to come in and grab this.
Yes.
Yeah.
Yeah. So you're asking me sort of.
Yeah. Do you see any big public companies that can benefit from this?
I don't know that I'm the best prognosticator on that.
Yeah.
I mean, I think it's going to be driven by sort of who can realize that. I mean, you're canary in the coal mine, that a crisis is coming, and who's willing to let go of their current revenue model. I think that's the hardest part for.
Yeah, I mean that's the innovator's dilemma in general.
Right, and you look at so we have lots of friends that would talk about sort of the Nashville healthcare market, and there are a lot of very successful.
They drive me crazy in Nashville. Yeah. I live in Nashville, but the healthcare market's hard.
Right, very successful businesses, successful from a financial perspective, that have been nibbling around the edges of healthcare rather than trying to drive real change. I think what we're talking about now in this next wave is hopefully real change in healthcare, and the organizations that are willing to recognize that earlier.
So a guest I had on previously, off camera, said, we're sort of riding a dinosaur to the tar pits. And I said, we got to go back on camera. He's like, no, I can't do that. So I can't say who it is, but that's exactly what they're doing. They're like, I'm still riding for a while. I know there's no real future, but it's paying my bills right now.
Yeah, I think that's probably not something you want on your tombstone.
Yeah, right.
Right. I mean, it's a little depressing, especially given, right, we're not coming up with the next color of lipstick, right? We're doing something I think that's important.
It's people's life.
And we're dealing with people's lives, and I think we have a responsibility to try to do the right thing. And there's a ton of opportunity to do the right thing. And it takes a little courage and a lot of hard
the reason
work.
I like being in healthcare is you can make a real difference in people's life and make a ton of money.
That's right.
Both. You don't have to choose. You can do both.
That's right. Yeah. Do well by doing good.
Yeah. Okay, so I know you love this next segment. I want to talk about politics.
Oh, goodness gracious.
My view, it's widely covered, is that Trump is going to push price transparency. He has an executive order. It's being challenged, of course, but it was in the Obamacare legislation.
Yes.
And so Trump is modifying it. In Obamacare, they had to put this charge master, which is, like you said earlier, it's the made-up number that no one pays.
Yes.
And they publish it, and it's not that useful.
And it's really, I mean, if you've ever, as a healthcare geek, I've gone on to a health system website and downloaded it, and then you open it up, and it's gobbledygook.
Yeah.
I mean, no one can figure out what the heck it says.
Right. Even you who are focused on it.
Right. And I really tried, and I couldn't figure out what it says.
Yeah. And they are intentionally obfuscating it. And so Trump is pushing this, and I want your opinion of, can it get pushed through? So what he's pushing is the network pricing.
Right.
So I want you to have to publish all of the prices with the Blue Cross, United, Cigna, Aetna. If Imagine is in that market, they need to publish the Imagine prices, because that's the American way.
Yes.
And it's just full price transparency. And then if you are more expensive and you're better, there's a lot of brands out there that are more expensive and better.
Absolutely.
My son wants a Lamborghini, not because it's a cheap car.
That's right.
Because it has this bullshit kind of appeal. And so, so I digress there. So anyway, do you think that it can get pushed through? I mean, everyone's going to fight it, but do you think it can get pushed through?
I would love to say I think it could be pushed through. I think we've had with pharmaceuticals a similar promise and push that wasn't successful.
Yeah.
And so my fear is that the sort of the forces of the status quo may have this end up in the same spot. I spent a couple years in the gas business, Right. And if you think about, if you're and it was a commercial fuel business,
Yeah.
but if you're a gas station, right, the price is on the street, and
it's posted
right
on
in
the
size
corner,
80 font, right? I mean, for everybody to
Yeah.
see, and we're talking about pennies, right? The gas stations compete at the penny to get people to drive in. Publishing prices matters, and will drive decisions. And you think about the way it works now, and put the sort of the transparency companies to the side, but generally people go get care, then a claim gets filed.
They get a bill.
They get an EOB
45 days later.
Well, and then they actually get a bill a couple months later,
Yeah.
right? When the claim actually comes through. It's a crazy way to have it work. And it's been working that way for a really long time.
One of the first things you said, which I think is right, but I had not thought of, is there's no motivation for a health system to worry about pricing.
Why would
no one's making that in their decision. There's no
way that you could.
Right.
And I mean, again, I think there was a belief, 4 or 5 years ago that people were going to, get on an app and look at, it's really hard.
Right.
And if you're already in the system and your doc says go to X and get Y done, it takes a special person to say, I'm not sure if I need that, or how much does that cost? Can I go someplace different? I think the reality is people haven't used those tools.
Right.
There's a ton of data that shows exactly that. I think showing how much things cost is an important part of changing the system. I think it's also really hard. And I know, Larry Van Horn, who we both know, feels very strongly that that's going to be different.
Right. I mean, I guess we'll see, right? Like, I'm in favor of, because it's going to change everything.
Right. It's hard to argue. You want to be if you're in an argument, you want to be on the side of logic. It's hard to argue against telling people how much stuff costs.
I mean, I tried to read the legal thing. It's pretty dense.
Bless you. Yeah.
But it seems like they're saying we'd have to build a really big Excel model. Like, they actually say in the legal thing, this is going to be a multiple 1,000-line Excel model. I have like 30 of those on my laptop next door. Like,
that's right.
It's not that hard to build Excel.
No, it's really not. Well, yeah.
And then there's this First Amendment right, that the right of free speech or something, that doesn't make sense to me. I mean, every person in the world that's not in healthcare publishes their prices.
Yes.
I don't see how it's a First Amendment.
Well, and not to disparage the carriers, but we
I like when it starts like that.
Yeah, that's right. That's like don't see a pink elephant.
Right.
I think when we have historically tried to get data to help our clients understand the current state that they're dealing with.
Their own data.
Yeah. There has not just been a reticence to provide the data. There has been an absolute
actively
violent resistance to providing that data. And when you hear things like, well, the data is the carrier's data, or it's proprietary. Our prices are proprietary. I have a real hard time understanding how that could be. And I think if you've got a business, if you're a carrier and your business is solely based on your price, right? If that's what you're hanging your hat on, is your network price, I'd have to say that's not a business that I'd want to invest in.
Yes, and I wouldn't want to invest in a lot of the carriers. Okay, so the question I have is, let's just for a minute imagine it goes through. I don't really believe that our wives are going to shop for prices that well, but I do think that new entries could come in.
Right.
So you could have a new insurance model, or you might have a new provider of care decide, gosh, in Nashville, all of these existing providers are charging a ton of money, and they're at full capacity. I should enter there. Where right now there's no information like that.
Right. I just to go back to something you said, I do think that my wife absolutely would. I think I would probably be the one that was the fast follower on that. But I think if she had the data, because we talk about this all the time, if she had the data to know where she could go get a mammogram for $2,000 less because the facility, getting it done at the hospital is $3,000 and getting it done down the street is $1,000. I think she absolutely would make decisions, especially in a plan where you're paying a lot of that out of your own pocket. It's
Well, that's great. I mean, my experience is that we only need about 10% of the people to shop like that.
Absolutely, and it's going to drive.
And then it will drive everyone down.
Absolutely. Well, and then they talk about like how much did you know, and again, it will go from what you said earlier, right? We find providers based on what a friend said or somebody,
right.
a billboard to both quality and cost, and I think making both transparent in the long run, that's what you got to do.
Now, it would have a significant effect on the Imagine business or the reference-based pricing business. Because obviously the reference-based pricing business, there'd be a lot of reference data out there.
Yes.
Right now you're having to do with Medicare prices, probably.
Well, so that business is two things. One, what Medicare pays, right, which is available, and also what the hospitals report as their cost for a service. So two different references for the pricing.
But in this case, so you'd go from 2 to 40 or whatever it is. So you'd have a much better view of
absolutely, and you think about sort of what we do at Imagine and how we've baked quality into everything that we do, right? Which is it's sort of embarrassing to say, right? It should be if you're going to go create partnerships and drive people to providers. How could you not have quality as part of the equation, right? How could
that's not their goal.
Well, fair, fair enough. But it's a great differentiator for us for the long run that we've already done that hard work.
Yeah. Okay, great. Now, if the Democrats win, so if Trump wins in the fall and there's another 4 years of Trump, that means a lot of things. But what it means is that he's going to keep battering on transparency.
Yes.
And I think there's a decent chance that over multiple years it could get pushed through. If the Democrats win, any of the candidates are going to be much more about all access. Whether you call it Medicare for All or something else, they're going to open up access, kind of like Obama did.
Right.
What's the impact of that if a Democrat wins?
So, who knows is the short answer. I'd say the last Democratic administration didn't create a single payer system. They provided care for a bunch of uninsured Americans, right, who really need access to care. And I don't think that's a Republican or a Democratic issue. I think that's an American issue. And if you talk to people like Senator Frist, who's certainly not a Democrat, he would say, we need to increase the access to care, right? So people are getting care.
Well, it's a human issue, human right issue. And it's a dollar and cents issue.
Absolutely. Do you want people to get care in the emergency room, or do you want to go for them to have a primary care doctor? Do you want them to have, a baby, a mother who's pregnant to have access to prenatal care, or do you want them to end up in the NICU? Again, it's common sense and basic health care. How we pay for that is an important piece of it. I think, we can talk about the ACA and whether or not it was. I think it started the conversation. But there were a lot of bad compromises that were made along the way, unfortunately. But it did start the conversation, and it changed a lot of things in healthcare, I think, for the positive. I think, whether it's, Trump gets reelected or the Democrats come in, my hope is that we continue to make it better as opposed to blowing it up and starting over, because I think where we are today is better than where we were 4 or 5 years ago.
And so do you see a Medicare for All or some kind of public version of health insurance available to folks that are not really old or low income if a Democrat wins?
So,
because that might affect the employer-sponsored.
Where self-insurance goes away altogether.
I don't think it's going to go away altogether for a long time. Yeah. But I think you could have an alternative that sort of chips away at it for a few years.
Yeah, I think one of the things that's scary about the self-insured, the commercial space, is if something doesn't change in the next 5 or 10 years, there's not going to be an alternative, right? Because again, we've turned the knobs as far as they can go on high deductibles. People already can't, sort of the normal American that's making between $30,000 and $80,000 a year can't afford a $15,000 deductible, so they can't afford the care they have now. If costs of medical inflation keeps going up by 3 to 6%, or or premiums keep going up the way they're going,
basically if wages go up at 2% and healthcare goes up at 6%, you can't make it.
Again, this is a math problem, and the math just doesn't work. And so we either figure it out, or it's going to get figured out for us, because people are going to just bail. And in catastrophic care, is
when you say people will bail, a CFO of a company will just bail out and not offer benefits?
Well, I think, they don't have that choice now.
Right.
But, okay, if people don't, so you play it through. If people don't offer health insurance, then what's going to happen? An individual can't afford to go buy health insurance without Obamacare. And so if that goes away, then what? Right? Again, I think if we don't fix the system the way it is, then I don't see another option than a single payer system. And I think my hope is that we can figure out how to do it on our own without having the government have to do it for us.
Yeah, and I'm a capitalist VC, right? So I think there's going to be
capitalist too.
There's going to be innovation like Imagine and like other companies that kind of rethink things from the bottom up and fix this.
I think that's the only way to do it.
I don't know that the government is going to help us fix it.
Yeah.
Exactly.
I think if we have to wait on the government to fix it for us, then we're in big trouble.
Right.
And but they're obviously a big payer in the system.
Yeah.
So I think there's a lot of opportunity for them to play a major role, and they have in the past. And
I think Medicare Advantage and Medicaid here in Tennessee, certainly, they are really helpful in testing things and doing innovation labs and trying things. And Medicare Advantage is certainly having a lot of success and some learnings. And then the hope is that translates to employer-sponsored or elsewhere.
Yeah, you would think, right, that employer-sponsored healthcare would be driving innovation more so than anything related to the government. I'd suggest it probably hasn't been that way, though.
Right. Yeah. Okay. You've been doing this for 20 or so years, working on healthcare, changing healthcare, helping people get healthier. I ask this to all my guests. What do you wish you knew when you started that you know now?
Yeah, that's a great question. I'm glad I didn't know how hard it was, because I may have chosen to do something else. Right. That's a great question. I think focusing on, and we talked a little bit about this, it's important to spend your time focusing on real problems and not just being part of the problem. Mm-hmm. To work in healthcare is a privilege, and to focus on sort of a mission-driven organization that's doing important work.
So I think that I agree with that completely. And if you had told me 20 years ago, I'm going to go do Imagine and really help employers make change, it might have been too early.
Yes,
right? So,
absolutely.
Working in a mission that you believe in is powerful, and what makes kind of it fun to get up and go to work every day.
Absolutely.
But you also have to have the timing right. So I think now in the next 5 years is the time when all this change is going to happen. I think it's the opportunity for our generation to make an impact. I mean, others before us in health changed things in different ways. We have a chance to recreate it in this.
That's
this
right.
time.
I mean, I think a couple other things. I think there's an opportunity for people who are just getting going, who want to work in healthcare, to go work in a big healthcare company, to understand how broken everything is, and then go
for 2 years
and just
learn
know
how bad it is,
yes,
and then
that's
jump
exactly
out.
Right. And then go and do something to be part of. And I've seen a lot of people who have done that, who've gone and done great things in healthcare and had a big difference, or made a big difference. So that would be one thing. I think to your point around the timing, we've said at Imagine for a long time now. What we don't want to do in 20 years is say, "Hey, we were right, but we were too early."
Right.
And so I think what we've seen is over the past couple of years, when we go out and talk to clients, probably 5 years ago, it was, "This is an interesting idea, but you're crazy," to now where we're getting calls, "Hey, can you come talk to us about doing this?" And that's been a really neat transition.
And I think it's probably like an exponential curve, right? It's slow, and then all of a sudden, wow, there's all these case studies.
Yes.
CFOs now have cover where, I don't know, several other CFOs around the country have done this, and nothing caught on fire, and they didn't have people storm off and quit, and it was fine.
Yeah, I think that's exactly right. And so it really has changed over the past couple of years, and there was a while there where we were wondering. So maybe the other thing would be, it takes, driving change in healthcare takes a lot of hard work and a long time.
Yeah.
And so, it's not a 2-year journey. It's a lot longer than that, but that's what makes it fun.
Yeah. Okay. Any other trends that we didn't touch on that we should have?
I'm curious to see sort of where telemedicine ends up.
Yeah.
I think it has huge opportunity that probably we've just scratched the surface on. I think there are a lot of big providers that are doing really good work. I think a lot of people are using it to avoid going to the ER or getting antibiotics and things like that. I think we're going to see more and more real care provided remotely, which is exciting, and hopefully will be part of the solution for rural areas. Behavioral health, I think, is a huge issue in this country. There aren't enough providers. Right. We've done a couple sort of projects where we've looked at this. There aren't enough providers. The access is not great. There's not a lot of quality data that's available. It's a really tough problem, and it's a big issue for the country. And it's comorbid with every other disease. Yeah. We had. I remember this is years ago now, when we were working in the Midwest in the winter, and we were doing depression screenings. Telephonically, and it was like
how can it be that
right? It was like everybody who we would talk to, and I don't mean to make light of it, but it's real. And so then you understand that all these people are having mental health issues. And what do you do to help them? And
we're not going to make new clinicians at the pace that we're going to pull people in. So
that's right.
We've invested a ton in support tools for clinicians and ways to get care out into the field.
Yes.
At all different levels, because it's a huge problem, and it's underlying all the other health benefits.
Absolutely.
You can't take care of your diabetes or cardiac care if you don't deal with your behavioral health.
That's right.
Health.
That's right. I think how we, sort of senior care. I've got, 107-year-old grandmother that, she's amazing, but how do you care for aging parents, aging grandparents, and then us aging, and support people in that? It's really expensive. It's a ton of work. How do you support the families who are giving care to their own family members? I think there's a lot of innovation that needs to happen in those spaces as well.
Yeah. Okay, good. Well, it sounds like we have enough for a whole nother show, so we can get back to that.
That's right.
Okay, thanks, Chris. I really appreciate you doing this.
You got it. It's good to spend time with you.